Hello, I'm Enola Proctor from Washington University in St. Louis, and I'm so thrilled to be part of your program on the fundamentals of implementation science. So as I'm sure your training course is helping you understand, the purpose of implementation science is to discover how we can increase and accelerate the benefits of research in terms of the discovery of new programs, policies, and interventions. Implementation science also seeks to tell us how to decrease or stop using interventions that are ineffective, that are wasteful, or harmful. Of course, the usual research is to test the effectiveness of quality improvements and evidence-based interventions and policies on people's experience and their health, their well-being, and their societal functioning. In implementation science, we add a few other constructs. We add a second kind of intervention, namely, and I know you've had a session on strategies, the how do we introduce the new interventions and programs that we seek to introduce. We're also interested in two types of outcomes, implementation outcomes and service outcomes. In other words, how do we help the uptake and the buy-in, and how do we improve the functioning of the clinic or the health system in making it more efficient, safe, effective, and timely. So this is the core of implementation science. I'm going to be focusing on how to select and measure various implementation outcomes. In a 2011 paper, our team identified 8 kinds of implementation outcomes, recognizing that these are certainly not the only ones, and we encourage the conceptualization and advancement of the operationalization and measurement of new implementation outcomes as we become aware of them. So the implementation outcomes that we identified and discussed in that 2011 paper included acceptability. Do people find this new intervention to be palatable? Do they like it? Will they adopt it? Do they actually start using it? Do they deem it as appropriate or fitting for their own skill set and for their clinic's mission and for the individuals that they're serving? Is it feasible? Are there the resources, the practical issues surrounding the capacity to deliver? Can the intervention be delivered with fidelity, or the ways in which it was intended to be used? And is it used consistently over time in the proper manner? Also, the implementation cost. Is it bearable? Can this system bear the financial burden of starting this program? How far does the intervention actually penetrate into the service system? Do only a few people get delivered the new evidence-based intervention, or does everyone, or the large majority of people for whom the intervention is appropriate, do they receive it? And finally, can the individual provider or the clinic or the health system sustain, maintain, or institutionalize the evidence-based intervention? So it's really important that we measure implementation outcomes distinct from intervention outcomes. For example, we can have a very effective intervention, but perhaps it's delivered very poorly, or there's poor reach or penetration. It isn't sustained. Unless we actually measure the implementation outcomes, we might conclude from the poor implementation leading to poor outcomes that actually the intervention didn't work, when it did, but it was never delivered consistently or well enough to have the effect that the intervention could actually have. And unless we measure implementation outcomes, we're at risk of reaching the wrong conclusion in our evaluation. So typically, and our group just published a review a couple of years ago around what the research on implementation outcomes research, and this paper is listed in your resources. We found that out of over 400 empirical studies of implementation outcome, more than half measured acceptability. The next most frequently measured were feasibility. That is it realistic? Can it actually be pulled off? And is the intervention delivered with fidelity? Far fewer studies were looking at cost, penetration, and sustainment. So how do we choose an implementation outcome, given that we identified 8 and new implementation outcomes are on the scene, particularly scale up, which is extremely important? Well, first, it's important to consider the barriers to adopting or implementing the intervention. And this requires experience with, formative research, or capturing the perspectives of the system itself. So once we know the evidence-based intervention that could help improve the quality of service, we need to understand, well, what's getting in the way of delivering the evidence-based intervention? What is the barrier? Is it too expensive? Is it that people don't like it? Is it that it's deemed inappropriate for the service setting? So that can let us know what the implementation outcomes are. And once we know the relevant implementation outcomes, or the most pertinent for this particular implementation initiative, then we're freed up to figure out what implementation strategy can help attain the implementation outcomes. So let me give an example. Perhaps a new intervention that is being implemented, there's some pushback because the providers don't really understand what it is, or they don't think it's relevant to the people that they serve. So once we understand that, we might use an implementation strategy of educational training sessions, with each session addressing, here's what this intervention looks like, here's how to perform it, and here's why it matters for the people we're serving in this clinic. And then ideally, this training would help improve the acceptability and therefore bolster the success of the overall implementation initiative. A second criteria is in choosing an implementation outcome is considering, where are we in the process of implementation? What is the stage of implementation? And there are a number of frameworks, models, and theories that describe various phases and help you conceptualize the phase that a particular setting is in during their process of considering, planning, or actually executing an intervention. And we have found that various implementation outcomes seem to be more salient at different phases in the implementation process. When a clinic or an organization, a health system, a social service system is just exploring the possibility of implementing a new program, they'll probably be concerned with, is this appropriate? Does this fit with our mission? Do the clients we serve need this intervention? Is it acceptable to our providers, to our funders, and to the people we serve? Is it cost realistic? When we're really beginning to dive into the preparation for an implementation, the feasibility and the resources become very important concerns. And then during the ongoing implementation, we want to monitor how consistently is this being adopted and delivered? Is it being delivered with fidelity? And is it reaching all the users of our service system who could benefit from it? And then later, we continue to need to monitor the fidelity or how well the intervention is being delivered and whether its adoption is being sustained. So some examples of this, when settings have been implementing antiviral therapies for HIV, and their clinical outcome of interest is suppressing HIV viral loads. Some of the most important implementation outcomes include, is this therapy acceptable for individuals with HIV? Is our service system set up to deliver this? And is it cost effective? Similarly, when implementing tobacco treatment guidelines, can we deliver those with fidelity? Can we train the providers well enough that they can deliver it well? Is the cost manageable? Is the organization ready to take this on? And can the providers adhere to deliver the guidelines? And all of these factors can help enhance the clinical outcome of interest, which is smoking abstinence. So a third way to choose an implementation outcome is by understanding and following a theoretical model or looking at data from prior studies or data from the particular service system. So what does a particular theory say about behavior change? For example, some theories say in order to change behavior, we need to change attitudes about it. And therefore, we would focus on acceptability before we would focus on adoption and fidelity. If we're looking at data, we might find that we really can't deliver the intervention to the entire consumers or users of a health system until the providers are trained well to deliver that intervention. If they don't have the skills and the knowledge and the confidence to deliver the intervention, they're probably not going to use it very often. I'm a big fan of focusing on the prior experiences of the site that's trying to implement something new. What have they found that worked before? And I always start my discussions with an implementing site. Tell me about a positive experience you've had implementing something new and what worked. And I usually find that implementation is more feasible when we know what the system has found to work for them before, what they're used to, and what is acceptable. For example, some hospitals may have weekly nurse training sessions, and if those are acceptable, they're used to going to it, they probably would find, the system would find it more feasible to introduce this additional new intervention. And then finally, it's really important, it's critical, it's essential to understand the context and the infrastructure of the community, of the implementing site, and the supports available to frontline providers. And just as an example, people aren't going to think it's very feasible to introduce an intervention that they can't afford. So some data might suggest that we have to crack that first and then work to help an adopting site be persuaded that they really can deliver this if new grant funding comes along or there's a way to do it in a low-cost way. So the third criteria is really turning to data and turning to theories and basing your selection of an implementation outcome based on what we know. So an example of task shifting, which I expect is a strategy you've heard about, training a different set of providers to deliver some care. Again, if we're looking at antiretroviral treatments, the implementation strategy may be to shift the prescribing of the medication to nurses rather than relying on physicians to do it. But an implementation outcome that's very important here would be the appropriateness. Do the doctors feel it's appropriate for the nurses to take this on? Do the nurses perceive that it's appropriate, or do they say, that's not my job. My job is to do something else? And very importantly, do patients and users of the clinic think it's appropriate to get their medication from nurses? So these examples suggest that different implementation outcomes are more relevant at certain times or based on data or understanding the context. And those are important factors in selecting the implementation outcome for focus. Now, over the past decade, there's been just a real many real advancements in the measurement of implementation outcomes. And I've provided several articles here that can help with the measurement. There are a variety of data sources for measuring implementation outcomes. Typically, we have overused self-report and studies of acceptability tend to rely on surveys and interviews, but observational methods are also useful. Observing in staff meetings what expressions of pushback or buy-in are expressed. Certainly, records of treatments provided are a very solid source of data for measuring adoption, scale up, and sustainability. Appropriateness, again, may be measured in many of the same ways as acceptability. For measuring fidelity, although it's expensive, observation tends to be the gold standard, but checklists can also be helpful at the end of each session or during a session, providing a card where the provider can just quickly review, did I do this part of the intervention? Did I say that? Did I deliver that part of the intervention? And then again, archival data such as time logs and budget data are more kind of hardcore and non-self-report measures of implementation cost. So data sources, if we're looking at data about the implementation outcome of appropriateness, where might we get it? At what level was it measured, and who provided it? Well, nurses may provide information about the appropriateness of task shifting. It may be individual self-report or quantitative survey items, all geared at capturing, did the nurses think the content and delivery of the training we used was relevant and appropriate to equip them for their day-to-day tasks? So in summary, I want to highlight a few key messages. First of all, implementation outcomes need to be measured distinct from intervention outcomes. And if we fail to measure implementation outcomes, first of all, we don't understand whether or not the intervention was effective. And most importantly, we don't understand where the implementation initiative went awry or what was the problem. Second, choosing the particular implementation outcomes to use in your study should be informed by the barriers that you recognize in the setting and in the providers. They can be informed by the stage of the implementation process, and finally by relevant theories and data. And then a final recommendation is, when you are actually reporting implementation outcomes, please provide detail about where you got the data and how it was measured, because this will help advance the field. We all learn from each other's experiences, and so the literature is a really important source of guidance, but only when we report the details. So thank you very much for listening. It was such a pleasure to be with you today, and my contact information is reflected on this slide. Thank you.